Josh, can you open our hui for us this morning, please?
Yeah, with my pleasure. Tēnā tātou te whānau. Nau mai hara mai ki tēnei huhunga e pai ki tiki a koutou. I raro I tēnei wā karaunatanga me ki, te mate o te karauna me ki. Hoi anō me noi tātou. E o ngā mano. Tēnei te whakamoemea atu ki a koe mo tēnei huhunga a mātou. Arahina mai ki au ki te tika, ki te poni a mātou. Manakitia mai ki ngā rawakore, ki ngā pani, ki ngā whānau pani o ngā tangata kua pāhuri, kua haere atu rā ki te pō tangotango, ki te pō uriuri. Tukuna atu tō wairua tapu hei manaki, hei tiaki hoki I a rātou, I a mātou hoki. Nei mātou tōhu nei mui tō aroaru, ka tuku I tēnei inoi, I runga I te ingo o tō mātou kai whakaora I Ukraiti. Āmini.
Thank you, Josh. Well, kia ora tātou. Nau mai hara mai ki tēnei hui a tātou. Just before we start our formal business, I would just like to welcome members of the public and the media who may be tuned in and watching our live stream today. This is a new event for us, so we hope it goes well for you and for us. As with all other organisations and businesses, we have been operating under strict restrictions for level 4, and in level 3 we will be continuing this, minimising our own personal movement and working from home where we can. So thank you for being with us today and for accommodating this new way we're having to do business at the moment. I'd also really like to extend my particular thanks to Jim and the staff. As everyone knows, this has been a very, very busy period, and our crew have worked really tirelessly over recent months. First of all, standing things up to get ready for COVID, managing the situation with testing and with the ongoing provision of healthcare and with our community relationships during the course of the last 6 weeks or so, and then much more recently re-gearing ourselves for the provision of health services over level 3. So tēnei te mihi atu kia koutou Jim, koutou Mark, thank you for your tireless efforts over this very difficult time for everybody. And also to the board, I know that we've asked a lot of you over particularly the last 4 or 5 weeks. So thank you for your continued engagement and willingness and capacity to come online at very short notice and keep abreast of what's happening in our health and wider hospital and the whole system. So thank you all for your over and above what would normally be expected of a board. So with that done, we'll start with apologies. Do we have any apologies? I understand Sandra may be still trying to get into... Oh, Sandra's here. Sandra, welcome. And we are still anticipating Rob and Meredith to come online, but so we'll receive them when they do. There's no other apologies from staff or anyone else?
No others that I'm aware of, Kim.
Okay, thank you. So apologies are noted. On the interests register, item 2.1, Sandra has sent through one updated interest, which has no conflicts with this meeting or this role, but congratulations, Sandra, for your appointment to the Animal Welfare Committee. So that's wonderful, that's great. If anyone else has any changes in their interests, can they please email them through to Rachel or signal them now if they are matters that impact on this meeting? Carl, okay, thank you. The interests are noted. And I also do just need to check that there are no formal conflicts with any agenda items. No, thank you. Okay. So we'll move on to the minutes from the 24th of March at page 6. Does anyone have any comments or amendments to be made to the minutes? No. So we need then to formally approve and adopt the minutes. Ka pai? Thank you. Are there any matters arising from the minutes? No matters arising. Action items. We had at page 11 at 4.1, the action was when we discussed ensuring we had an arrangement for governance backup. Jim, can you just update us on this action item, please?
Yes, so you'll see there in the table that everybody except for Josh has provided the backup person for themselves in relationship to that. Josh, I think it's just a case of just completing that action for you.
I sent through an email through to Rachel, just outlining who I wanted, but they haven't responded to me yet.
Thank you.
Good, thank you.
Andy, you have a question?
Yeah, I just note from the minutes last time that now was an apology. Should he be an apology for this, or is he a regular attendee, or what's his position?
He is a regular attendee. I have not heard from Na.
Kim, I had thought he was attending because I was in communication with him last week, and I know that he received the invitation, and so I think he may have been attending, but something else might have called him away.
We know he's very busy because he's been called in back to work, so his availability has been a bit more constrained over this period. Thank you, Andy. So we move to item 5.1, correspondence from Honourable David Clark, which is a letter in response to our request to equity support. We're very fortunate that the letter has confirmed equity support to the tune of $20 million for the DHB. Just to note, this is liquidity support. There are some very specific requirements around that, including that we don't increase our underlying cost base. We may need to review our delegations given some of the matters raised in the letter. So Jim will ask you to talk to us about that. We do have to make a formal representation on a regular basis to the Minister, and our first one has to be provided in September. So we'll schedule that to come to both the Finance and Audit Committee and the board in September. I think it's important that the board reviews that, given that it is a board representation. And we will need to have a discussion, probably not right now, but once the staff have had some opportunity to work through things, on how we actually achieve the financial expectations through to year end, particularly given the reduction in planned care. So Jim, I'll pass over to you if you've got any matters to raise on the letter from the Minister.
Thank you, Kim. And just to note that Meredith has just joined the meeting.
Thank you, Meredith.
So this was a little bit of a surprise in that we got $20 million worth of equity support as compared to the $14 million of support that we asked for, and that noting that that was back in November last year. And so I would think that this is a conservative approach from the Ministry, allowing us to take into account the ongoing trading conditions that we're in going into the next few months. Our cash position has actually held up better than what we actually had projected anyway. So this will see us through for some period of time now. I don't think we've got an absolute projection about when this will see us through to, but certainly well into the 2021 year. Yeah, so that is good from that point of view. The actual conditions within this letter are virtually identical to the conditions that we're currently operating under. So last time we got equity support, which is probably about 12 months ago, 18 months ago, these are exactly the same conditions that we've been reporting on every quarter since that period of time. So if you remember, I'm not sure, there should at least been one of those reports that has come up in the time that the new board has been in position that have gone through the board and have gone down to the Ministry of Health for them to utilise for reporting to the Minister. So they are very much the same conditions that we've had in place all along. And in terms of what the requirement around operating within budget is concerned, I think I might address that a little later on when we start talking around the current financial and projected financial position for the DHB to the end of this year.
Thank you, Jim. Does anyone have any questions or comments on the letter from the Minister? Thank you.
Sorry, I couldn't reach my blue hand in time. So can you explain to us, please, Jim, we asked for 14 million to cover our deficit. They've given us 20. What happens to the excess 6 million?
It's equity, so it just improves our cash. Cash just sits in our bank account. So at the moment, we get paid at the start of the month, on the 4th of the month, we get our funding from the DHB for the DHB a month in advance. It sits in our bank account and gradually erodes away, and about the 20th of the month we start to go into overdraft. Now we will stay in positive cash balance the whole month through and some, and gradually as our planned deficit continues, we'll start to erode that again, but we're not thinking that we will get into any kind of, we never got into any kind of cash difficulty, but we're heading in that direction. We wouldn't have that problem again until sometime in 2021 at our current rate of rundown of cash. The other thing that Craig just mentioned before was that the cash arrived in our bank account last night. Friday night. Yep.
So just supplementary question. Obviously, that's going to not be taken as available funds or tapped or a lolly scramble. That's going to be ring fenced and left there to be prudently managed.
It's equity, it's not funding. So it's just purely to restore our capital balance, our cash balance within the organisation, so we're able to pay our creditors on time and our staff, of course, and all the other operating costs of the DHB. You may remember that as a DHB, we're all part of a pooling of available funds that DHBs have on every night. So that goes into a pool, and some DHBs are cash positive, some DHBs are cash negative. As I said, we're cash positive until about the 20th of the month, and we're cash negative. So then we rely on the cash positive DHBs. So that this is an ineffective way of replenishing that pool, and may be a reason why the amounts are higher than was originally we originally requested. I know other DHBs have also received equity funding, and those amounts have also been higher than the original amounts that they requested.
Thank you, Jim. Andy, you have a question?
Yeah, just to clarify that, will we be getting an updated budget?
This doesn't affect our operating expenditure. It's just purely replenishing our cash reserves, so it doesn't change any of our operating budgets.
Anything further?
Yeah, so it's an equity injection. The owners have put more cash into the business to keep the business operating.
So just to be clear for everyone, that this is not funding that's available to us to just spend. This is funding to shore up our cash position and make sure we can meet our commitments. Okay, so we'll note the receipt of the Minister's letter, and I've asked Jim to make sure that we send a thank you letter to the Minister for our equity support. We'll move on to item 6.1, the performance dashboard. So just on this, the Minister has been very clear with chairs that the performance dashboard does remain critical. So although he's very aware of all the additional demands that have been on the health system, he similarly wants to make sure that we do continue with the provision of our health services more generally. And he's not wanting to see a large deterioration on our indicators arising from COVID-19. So when I looked at the performance dashboard, again, I want to congratulate the staff. I thought it looked really good for the month. Probably the main deterioration, as expected, is in planned care, and we planned for that deterioration. And probably just some other items where we do need to turn a bit of attention to. So Jim, can I pass this over to you to lead us through the performance dashboard?
Thank you, Kim. You're quite right, but around that dashboard, but of course that's March, so we didn't go into lockdown until later in the month, and much of the activities of the DHB were the same for early months, although things started to taper off towards the end. One of the most concerning things in there is around childhood immunisations, and I think there is a couple of aspects to that, and we know that that situation is one that's receiving attention at the moment. The two issues there was parents have adhered to the whole lockdown concept and have thought it not appropriate to take their children out for childhood immunisations at this point. And at the same time, early on, primary care was wanting to make sure they had the capacity to deal with an expected increase in numbers of people coming into their practices with respiratory and other conditions, and have and some have been passing messages that childhood immunisation was not a priority at that time. So we've corrected, attempting to correct both of those now with some advertising that we put out. Obviously the practices are back on track again with that. The outreach immunisation service that we run has gone mobile to try and get out there to get people. So we're really into that to rebuild that and make sure that we catch up again for babies, because the last thing we want is for those childhood illnesses to have a resurgence in this period of time leading out from the lockdown period. The other one that is in there that I know is of interest and has been topical around the country is around faster cancer treatment and making sure that people are receiving their treatment within the recommended timeframes. You'll see that that is the case at the moment, and our team are very hot on making sure that people don't run foul of the lockdown in terms of getting their diagnoses and the commencement of their treatment. So a lot of focus on that as well. Yeah, and then a lot of the other indices in there I'll talk to when I get onto my report in relationship to some of the throughput indices.
Thank you, Jim. Hiki.
Oh, kia ora, Kim. Just two questions. One with the immunisation. It's great to see that the paediatric outreach nurses are going to provide a mobile service, and I'm not sure which immunisation parts of the program that concerns. Was accessibility in terms of transport for parents to get their children to the GP to be immunised, was that ever a factor in our low rates prior to the lockdown?
So the outreach immunisation service is not actually the paediatric outreach nurses, it is actually a service provided through the public health nurses. So it is a specialist nurse and a hāwhina that have been in place for years in terms of working with primary care around finding and reaching out to some families who have found it difficult to get into primary care for their children to be immunised. And so that's just really utilising that resource even more at the moment. We've been able to prioritise that, as some of the other services that public health nurses provide aren't happening at present. And so they've been able to put a bit more concentration on that. In terms of transport to getting in for vaccinations, I think that has always been a factor, and the outreach immunisation service is one way. So the service comes to you, but I know that both of our iwi providers are very keyed into that factor and will provide transport for families to get to general practice if necessary to be able to provide that, to be able to get vaccinations. So that is a feature of the services such as the two iwi providers provide.
Okay, and then my second question, Kim, was around the faster cancer treatment. What about for those people who need to access surgical services out of the region? How's that being managed?
So that's always been considered to be urgent treatment, and so those people have gone for those either urgent MRIs, PET scans, or surgery out of district. That's considered to be under lockdown rules as things that have to proceed. So those surgeries have continued, or procedures.
And that's the same for our patients here?
Yes, yes. So if people here have needed to go over to Hamilton for a particular operation or a particular diagnostic procedure, those have continued on because they are considered to be essential.
Thank you.
Amy, you had a question?
Yeah, it was just in regards to the vaccination. So out of the percentage of babies that aren't vaccinated, have we got a breakdown of information as to how many of those parents have declined, and then how many are actually just struggling to get to the clinics?
Yes, in a normal month, that level of detail would have been provided, Amy, in my report, but unfortunately this month I haven't been able to source that level of detail, but normally we would have rates of decline in there. The actual rates of decline are usually around about the 5% rate, 5% mark, and that's the, but sometimes that can go higher, and that's partly why at times we haven't been meeting the target levels of childhood immunisations. But I'll make sure that comes back on stream again next month so you can see those rates.
Josh. You're on mute, Josh.
Aroha mai. Morena whānau. I wanted to ask about our ash rates, and I'm assuming over this COVID-19 time we've had like the rates, our ash rate would have definitely have massively dropped from what we've heard that, and we've kind of can assume that from people staying away from our hospitals. I was wanting to know, do we have any ideas in regards to how we're going to account for maybe that anomaly number, because it might not truly reflect the actual state of play in regards to ash rates, because it's for me it's one of those long-term things that I think that we need to make sure that we're staying cognizant of, and I didn't want us, because it's reported on 12 monthly, I didn't want us to be kind of in a position 6 months from now and a huge dip that's occurred over this month, possibly even next month, kind of not reflect the actual not reflect the reality of the situation. So I did want to ask, has there been any thought given to that?
So you're absolutely right, and I think I made a little bit of a blunt comment in my report that most of the stats that we've been reporting of are really difficult to make any comparisons between the last 5 weeks and prior to that, and childhood ambulatory sensitive hospitalisations, for those that maybe are listening online, what ASH means. Those hospitalisations are clearly and have been absolutely reduced in the last few weeks. In the last week or so, we've had long periods of time when there's been no children in the children's ward, and it's this precise moment there is no children in the children's ward. This is a very good thing if it means that we've been able to manage the care of those children in a different way, which means that they're not requiring hospitalisation. I think there's 2 factors in it for children. One is that parents have been very, very careful around their children, as you would expect, and are making sure that they're not going out of lockdown, and unless they absolutely need to. And I know that there have been definitely admissions of children over that period of time where responsibly parents have sought advice and help, and the children have been hospitalised. But at the same time, we do know that the rate of respiratory illnesses within the community is virtually zero at present, and that is because we've all been in lockdown, and as has been described before, while we've been in lockdown, and that COVID-19 has quite a long gestation period for illness, most of the other respiratory illnesses that affect children and cause them to be hospitalised are very short generation. So while 28 days is 2 cycles for COVID-19, is probably about at least 8, 9 or 10 cycles for other respiratory viruses. And so we're seeing that. We are seeing that in the fact that the children's ward is empty. We're seeing that in the reporting that we're getting from general practices, that they're just not getting people ringing through and asking them about childhood illnesses for their children. And so this is that's the other major reason why this change is there. So yes, I think we will have to, when we're looking at reporting our ash rates, cut that period out as being quite extraordinary circumstances, and then see what happens as we come back. This is really in line with what we have been thinking about and know from our COVID-19 experience, is that many of the things that have happened while COVID-19 has been a threat to the country have brought about positives, changes. We're not going to be able to replicate at the start of every winter a period of 5 weeks where people are locked down, which will have a massive effect on the circulation of respiratory illness within the country. But we are, I think, seeing a much better realisation from the population that if you are sick, you should stay away from school, you should stay away from childcare, you should stay away from work, and you should stay away from one another as much as possible and stay within your families and not spread these illnesses, because of the massive impact that they have on people's lives and on hospitalisation. So we are believing that this is something that's really useful, that's coming out of our experience here, that really highlights what everybody knows, is that if you're coughing and sneezing, you're passing it on, because that's how the viruses work. So if you can stop that, you can get a major difference in the impact on families and hospitalizations in this case. So that's a really strong and good message that we've got out of our experience. All of us have got that experience.
Thank you, Jim.
Are there any other questions or comments on the performance dashboard? Meredith.
Firstly, I apologise for my lateness. My schedule was a little whoa. Anywho, I just wanted to ask Jim, in respect to the immunisation mobile framework, are they going to be inundated with other questions? I'm just aware of the time and space we're in, and they're going out there to do this quite important work, and how will that be managed? I guess knowing that all services probably at the now are going to be given or getting quite a lot more kind of questions asked by resident citizens in regards to health, and so and they may be able to obviously glean other good information that can be used. Is there an expectation in respect to the time that they have been given to do a set task that may take up more time answering questions that people may have? So I was just interested in that space.
Yeah, I think the answer to that question really is that the primary relationship between families and the health service is within their well child tamanaki order providers. And I know that those well child tamanaki order providers, have been providing services all the way through this, but also have been actively contacting families to see how they're getting on and to answer questions at the time. And the other important relationship that they have is with primary care as well. So there's that three-way relationship between families with young children and their well child tamanaki order provider and general practice or primary care. So those questions there, I'm confident will be able to be answered, and that already it's been quite proactive in making sure that families are informed and they're being kept in touch with over that. The outreach immunisation services, as an adjunct to that, it backs up the work that the other two providers are able to do, and it really comes in as a specialist service where there are difficulties for families to be able to link up with immunisations and come to the home or come to the place where where the family are or the children are, so that immunisation can be done. But between the nurse and the kaiawhina that goes with that, they're able, of course, to answer the wide range of any questions that the family may have as well.
Tony.
Kia ora. Jim, the acute readmissions rate, I was surprised to see the jump, although it's below the year-to-date average, but the over 75 jump to 11%. Any particular factor at play there?
I don't know if there is a factor in that or not. It does move around month by month. You'll see there's quite low numbers in there. So and also there's quite low numbers of people coming through the emergency department as well and being admitted. So a factor of difference of one when you've got smaller baseline numbers can make quite a difference in there. That's another one that we'll have to see what that looks like over coming months. But it is one to keep a track on, because that would be one of the ones that would say, hey, we haven't managed the situation as well because we've got lots of people that have come in and then have been readmitted later.
That was my concern, thank you.
Any further discussion areas from anybody? No, kapai. Thank you, Jim. We'll note the performance dashboard and move on to the chair's report. Firstly, in terms of what I've been up to, as I'm sure you'll appreciate, I've been spending a lot of time on Zoom. So it's been almost entirely dedicated to COVID-related things since we last met as a board. I've continued to join the daily incident management team meetings to just keep abreast of what's happening through the Emergency Operations Centre. We have had a lot of liaison with the Minister and the Director General. So all chairs have a weekly teleconference with the Minister and Director General. Manuataki DHB chairs and chief executives similarly have been meeting on a weekly basis. I appreciate that the board's ongoing attendance at its weekly briefing on COVID, and similarly the subcommittee that we established has commenced meetings. Although it's delegated to make decisions, it hasn't taken any decisions on behalf of the board. But I think what it has been a very useful forum for is for Jim to be able to test thinking and direction on some things and to get a steer. So we've been able to do that in terms of looking at how our testing regime is going and stepping out next stages of testing. And we've also commenced a discussion on capital works going into level 3, and I think we'll pick that discussion up again in the public excluded part of this agenda. In the board papers, there is a set of slides that has been provided by the Ministry of Health. And so they've been doing a lot of work to make sure that the sector as a whole is coordinated. And this is a set of slides to support governance in making sure that we are asking the right questions at the moment. So we received these slides a few days ago, I think, Jim, after last Friday's teleconference. So I haven't asked Jim to report against these slides for the purposes of this meeting, but I think it will be useful if we can get a sense and level of assurance over the questions raised in those slides at our next board meeting, and if there are any issues in the intervening period that cause Jim or members of the board concerns, they can get raised directly with me, and we'll look at how we address those between meetings. So does anyone have any questions of me over the last month? Tony.
First up, Kim, I want to acknowledge the amazing job you have done over the last month. It's been really, really great having you leading the waka. In relation to those slides, I thought they were really amazing, really poignant, really hopefully what you'd expect from the MOH in this situation, and mirrored some of the thinkings, discussions we've already had on our Thursday hui around planning for the next stage. Our next board meeting would be when, because I would be concerned that it would be too long between information provision in relation to those slides. Some of those questions raised by the ministry seem to be shorter timeframes and what would be between now and our next board hui. So could we maybe have some sort of interim report or update to us, because obviously those are very high level expectations, very specific questions. Some of those are very pointed questions, and we just want to make sure we don't drop the ball.
Okay. Jim, do you have a comment on that?
Sure. I haven't prepared a line-by-line response to those questions in there, but I have certainly been through them and quite happy to respond to any of the questions that were in there. So that's why I was wanting them to be in these papers, so that people could see that that's the sort of level that there's the expectation of DHB boards to be operating at during this crisis, and it's completely in line with what Kim, you and the board have been had in place in any case. But it's a summary document, it seems to me. And already this morning, I know that there has been that conversation around how we are tracking some of the service indicators that we've got within the DHB. How are we seeing how those are going? So I think you're exercising your functions as a board already in relationship to that, and I'm sure there'll be more questions coming up, but I'm quite happy to go through them if you would like, to just provide some assurance around what we are doing, but I can and certainly write that up as well in relationship to all of these.
That's a very good point you raised, Tony, and I'm wondering if it might be most useful if we could ask Jim to just basically prepare bullet points against each of the questions, and for us to address that in our Thursday afternoon meeting, so that the board as a whole gets an opportunity to have a look at this governance question, rather than asking Jim to go off the cuff today and for the board to respond off the cuff without having looked at the answers. Does that seem like a reasonable way through?
To talk with that, yeah.
Okay. Just a question, Jim, would we need to furnish that information publicly, the response to the questions?
I think it would be very appropriate to furnish that information publicly, and we can certainly do that. I mean, these questions there are public, that the public have seen, and so yes, they would have an expectation, it seems to me, to see what the answers are. So for any members of the public or the media who are involved in this meeting, just to signal to you that we will have a paper, a summary level paper on that, and it will in due course appear in the same place as you can see the papers for today's meeting. Ka pai? Just an update, there are currently 6 people who are on the live stream.
Great. Hello all, welcome. Okay, so that's all from me if no one has any further questions. We'll move to Na's report. Sorry, I just have to pull that up. Josh, did you want to speak to Na's report in his absence?
No, really, it's more of a mihi, in regards to the echoing the sentiments that you provided at the start of the board hui in regards to Jim and the Hauora Tairāwhiti's whānau's mahi and efforts during this COVID-19 thing. So yeah, I absolutely endorse his sentiments. Yeah, so it's quite straightforward, I feel.
Ka pai. Thank you. So we will note Na's report. Sorry, my dog's just bark. I'm just going to go on mute and pass over to you, Jim, for your report, please.
Thank you, Kim. I just wanted to lead this off by really mentioning your role within our responsiveness as an organisation to the current crisis that we have been in. I think that the amount of understanding and effort that you've put in to ensure that the organisation and our community are protected as best as possible from COVID-19 has been an outstanding feature. I have never been through a situation in my work life like the last 5 weeks or so, a little bit longer than that, in relationship to my job and this community and the health of our community. And to have you taking that leadership alongside the board as being one of the highlights of that period of time in terms of your, as I say, understanding and responsiveness, not only in this organisation, but in the community as well, because I'm very aware of the leadership that you've provided in many other forums and really put the DHB and health up front for people in some of the decision making that's occurring elsewhere. So I wanted to thank you for that and to make it really clear and public around the level of that. You've been available basically 24/7 over that period of time to me and to this organisation and to health in this community. So thank you for that. In terms of my report for this month, I really, from a financial point of view, the result is pretty much in line with where we have been going. We in that month saw some increased expenditure around COVID-19 as we geared up and hired some extra staff members and geared up to prepare for the effects that we were expecting to get at that period of time. We certainly ordered a lot more stock in and set those systems and processes up as a DHB. And we are doing a reconciliation around what that looks like so that we can see what the impact has been on the organisation financially over this period of time. You can see there in some of the indices that have been presented in that report that some of our other areas have tracked a little bit better this month. Some of our negative variances, while still there, coming back down again from where they were in peaks. And I guess this is one of those other kinds of stats that we've been looking at month by month over a period of time that are will be really changed by the last period of time that we have been in with. So things like our expenditure on staffing costs, for example, or supplies and expenses will be quite different now because we've had very constrained services over the last month or so, and that really won't show up until we get into the April results. So there was only a small period of time in these results that were covered by the effect of the COVID-19 pandemic. We are still projecting at this point to be overspent for the year, although that is a difficult projection to make at this point. Difficult for a couple of reasons. One is that we've got that underlying expenditure pattern that we've had, and we can't really, with any great definition, see how that might change in relationship to the ongoing, to the next few months. For instance, we know that our elective services production has very much reduced over this period of time. So there has been a lot less in consumables in relationship to that, and also with the very reduced numbers of people coming into the hospital over this period of time, that will have an effect on reduced expenditure there. But we've also had other expenditure increase, particularly around areas like personal protective equipment, and we will have to see what the full extent of those sorts of factors are as compared to the reductions. Our staffing costs will also be another one that we need to keep a close eye on. We have had we've had additional staff added in for some key roles, and we have been carrying, and I mean that in a positive term, our staff through this, so that we have had periods of time where our staffing levels have been very, very high compared to the numbers of people actually in the hospital. Our staff have been taking annual leave and have been conscientious in assisting us to be able to do that, which will have an effect on that. But we are finding that there isn't a great appetite to take lots of annual leave at present, because people like to take annual leave for recreation and relaxation, and that's not so easy to do when you're in lockdown or in level 3 as we are now. So we do expect that some of those things will give us more definition when we get the April results, in which will be one whole month trading under those different circumstances. I have included the usual graphs in there, and you can see at the end point of most of those graphs the drop-off in acute admissions across virtually every area of the hospital, and as I say, that we will see how much longer that goes on for. I know that last week we had an increase of utilisation of the hospital. We're up to about 50% occupancy in about the middle of last week, but that dropped away again, and over the weekend that's been down at about 25% occupancy of the hospital over that period of time, and we've been enabling staff to take leave to cope with that situation. And on page 24 there, the graph of ED arrivals, I can say that in the 17-18 year, on average, there were 53 people per day attending the emergency department. 18-19, that went up to 57, and 19-20 in the first 6 months of this financial year, that went up to 59 people a day attending. In the last 26 days of April, that's down to 34 on average. So you can see a very substantial reduction in utilisation. And if you have a look at the graph on page 26, you will see that most of that reduction is in people of triage categories 4 and 5, as would be expected. So that is people who are utilising the emergency department for whatever reason, for primary care activities in general. So those are the sorts of attendances that are no longer occurring. So it's reassuring in that what we're seeing there is that people with higher acuity, and just the triage level is not a perfect measure of that, but those people with higher levels of acuity are still coming to the emergency department. That's as good. This is what we would expect, and we're out there advertising to the public that the health system is safe. If you need it, please do not hesitate. Please phone your GP, dial 111, come to the emergency department. If you need healthcare, don't hesitate to use the system. And that data, and that's just one early, just the month as we started to go into the situation, is showing that was the case. We are still, though, concerned that there are people out in the community who've had mild conditions, who those conditions may have actually been improved by the lockdown period. For instance, those people who suffer from angina, where being in a not out in a work situation, stressful and difficult work situation, and has meant that their rate of angina has decreased, and we are expecting people such as that to want to come back into the system, or need to come back into the system as well. As the alert levels start to drop, and we get more people coming back into work, and the normal stresses and strains of lives come through, and people also have time to attend to some of the symptoms that may have manifested themselves during this period of time, but they felt constrained from going out and getting some things happening about that. And then on page 27, there are a number of points that I just had listed there, some of which we've been over before, so I will just quickly zip through those because just to make sure that if there are any questions that you are aware of them. In terms of testing, we've now tested 1,815 people here, or swabbed 1,815 swabs. That won't exactly people, because some people have had more than one swab, but generally it's pretty close to that number. So say about 1,800 people. So that's around about 3.6% of our population, which is a comparatively high rate of testing. The proportion of Māori within that is well up over the 50% mark now, and we have seen that because of the amount of community-based testing that we have done in the last week or two, and deliberately been out into communities to see if we can try and track down the virus, and have not found it whatsoever. So over those 1,815 swabs, around about 1,800 of them now have been processed, and there's still only 3 people who have tested positive for COVID-19 in Tairāwhiti over that whole period of time, over that whole 1,800 swabs that have been taken. We are still continuing with some community-based testing this week, but this week will be the last week in which we will do that, because we've got a very good picture now of the fact that both within Tairāwhiti and as a country, there is no evidence of community transmission of the virus. All of the cases that are now being identified are related to current clusters or people with overseas travel. And so that is a very good situation to be in, but does really highlight the importance of, as everybody knows, of everybody still sticking to the alert level 3 rules in terms of maintaining social distancing as the primary function there, that we're going to be able to prevent the resurgence of the virus, and also making sure that people do contact the health system, either their clinic, their GP, or Healthline if they do display any symptoms of a respiratory illness, and a decision is made whether they need to be tested. There has been, I know, some feedback in the weekend of people going to the community-based assessment centre and not getting tested. That will be because they are asymptomatic. There is, apart from the community testing that we've done, where we have tested some people who are asymptomatic, we are now focusing in on only testing people who are asymptomatic, because that is how we will get very much onto the whole trail of test and then contact trace and stamp out any possibility of the virus from spreading in this next phase. There was an interesting piece of work that the Director General talked about last week on his, he joined the regular teleconference, the video conference that the Chief Executives have with the Ministry on most evenings of the week. He talked about the infectivity factor. I'm not sure that's quite the right term for it, but in my terms, that is where one person has the virus and then passes it on to other people. We've been successful in keeping that to 0.4. So just so one person passes the virus on to less than half. So one person passes on to 1 and 2 other people, less than that, and that is an extremely good rate internationally, and what we're aiming to do as a country. And what he talked about was that we need to keep that rate less than 1 as we move into alert level 3, and then making any decision around moving out of alert level 3 into alert level 2. And around 1.1 would be the maximum that we would be able to tolerate before we had to really consider what we were going to be doing next. And the fact, so that would be approximately one person getting it and passing it on to just one other person would be a really trigger factor for us. So that will no doubt will absolutely be something that the Ministry is monitoring over the next period of time. So that the other thing that I'd say about the testing and that we've done last week was just really helped us also to be more confident about our contact tracing. We have beefed up the resources that are available within our public health team and as a country around contact tracing, and that better integration between what happens locally and what happens nationally. Our experience around contact tracing was that for the 3 people who tested positive and the 1 person who was probable for the disease, that those people were extremely responsible in making sure that they maintained the lockdown requirements, stayed in their bubble, and therefore had absolutely minimal contacts with other people over that period of time, which made it very, very easy to contact trace. We may not be so lucky if there was another case. So we've got the additional support nationally for our local team. We've got all the contacts to make sure that we can get out there and find the contacts of anybody. And as an example of that, where we have got people coming into the hospital now for, in fact, we've done this right from the word go. We've kept details of people who've come into the hospital to make sure that we know who's coming in and where they are living and what their contact details are, so that we can contact trace them. And that is, of course, something that all businesses that are open in this period of time are also doing, to make sure that we are really effective around our contact tracing, because it's such a vital function for us going forward. Just on the financial reporting, I did talk a little bit about that in relationship to some of the patterns and additional expenditure that we have had. We've also are working with our internal auditors to make sure that some key aspects of the expenditure are going to be audited directly, and a really good example of that is the setup of our community-based assessment centres, which occurred at PACE, and we're getting a special internal audit review of those, because those are key functions that you and the public will want to be assured about, and myself, that we have done those in an appropriate fashion. We talked about equity injection, alert level 3 planning, and now authorisation, anyway, you get me, of that plan. We have, from today, widening the amount of services that are available from the hospital. We have been functioning around those services that are urgent, non-deferrable services over the period of time during the initial part of the COVID-19 response. Now we are gradually winding those restrictions back and are increasing the numbers of people coming through. For instance, with our outpatients department, where we are going to be operating that on the basis of 4 streams for people to come through there. There is the stream around immediately responding to referrals that general practitioners put through. That's a function that we've had in place for probably at least 6 months now, and we are going to be making sure that that is across all of our services. And this is where a GP will put in a referral, say, with the details in a system that's called BPAC, to refer on a person with all of the details about that person and why the GP would like that person to be seen by a hospital consultant. The hospital consultant reviews that, and then if it's appropriate, will immediately communicate back to the GP with some advice around the management of that person. It may be that the GP can carry on managing the care of that person with some advice, quick advice from the specialist, or it may be that there are some other diagnostics that need to occur that the GP can organise, so that the consultant can have a better position about what is happening with that. And of course, there will absolutely be instances where the consultant needs to see, the hospital-based consultant needs to see the person. So there's that immediate response. Then there is those people, as we have already been doing, who can be seen via video or via phone consultation, and we will carry on doing that, making that option available for patients to be able to do that. We are finding that people are very amenable to that option, because it provides them with a relatively seamless and quick pathway through the system, and on recommendation from the consultant, we'll definitely do that. That is, of course, most often relevant for people with follow-up appointments who would have come and seen the consultant previously, but are now having a phone consultation or a video consultation with that instead. So we will make sure that stream is even more beefed up for people. And then, of course, there are those people that still absolutely require a face-to-face consultation, where an examination or other important information may be required and can only be done on face-to-face. There will be processes for people to come into the hospital for queuing and for social distancing within the consultation itself, and then any PPE that is required to cover that, to provide assurance for the person being seen and for the staff that are providing that, and also as part of that, keeping a record around who was present, so that we can contact trace should that ever be necessary, following up on that. And then the fourth stream is is one that we've been wanting to do for some period of time, but has really come into play very much with this scenario, which is a joint consultation between general practitioner, the hospital consultant, and the patient, usually in a primary care setting, so that there can be very quick work through around how a person's condition may be managed, and thereby improve the responsiveness and reduce the chance that that person will need to come into the hospital setting where that can be done. In terms of surgery, same thing in terms of increasing the range. So we've been focusing in on those people that have needed it in areas like cancer, as Becky was talking about before, but wider. We won't be getting into areas such as joint replacement at this time, but we do expect that that would be soon into alert levels 2 when we get into that in the coming weeks. So people in the community will be kept abreast. Just to remind you that all of the people waiting were reviewed by consultants right at the word go, and we are keeping a review on that to make sure that that people are not coming to peril as a result of this. But we do expect that some people would have deteriorated over that period of time, and we would be advising people to stay in touch with their general practitioners to should things change, then their GPs can also provide an update for us, and we can take that into consideration around seeing people. The hospital reconfiguration, we are still operating the hospital in a different manner that we put into place to make sure we have the capacity, staffing, and just sheer physical space to cope with large numbers of people who may have been admitted with COVID-19. As our experience has shown, that really hasn't materialised. But we're still maintaining that configuration so that if there was a surge in the need for capacity, that we would have that. As part of this, we reconfigured our intensive care unit to create a dedicated COVID-19 isolation area for people. We're still keeping the unit functioning in that way at present, and we will have therefore created close observation units in our surgical ward and in our medical ward, so that we can manage more of the people there as opposed to being in our intensive care unit. And that is a change that I think would be entirely likely that we'll keep in place going forward, not in terms of the total reconfiguration of the intensive care unit, but even when we go back to operating more in the new normal that we will be having as a health system, we will still continue those closer observation units within our ward setting to be able to spread the load between our intensive care unit and our wards and be more effective around patient management. Technology use is just really signaling the fact that we have had a very large uptick in the utilisation of technology, of IT in management of systems and processes. The fact that you all have this on Zoom at this precise moment and that we're live streaming it is two perfect examples of that. That has put a large amount of stress and strain on our IT team, who have risen very admirably to the challenge of that, and we have to give credit to Max and his team for the work that they have put in over the period of time to do this. Demand management is just really just signalling about the fact that we do believe that there will be a surge in demand from this week onwards, as we come out of alert level 4 and more people feel confident about coming back into the health system. Again, although it's always been well streamed, we've always kept people who had COVID or were suspected for COVID separate from those people who did not. And that, of course, relates to the new normal that I've talked about before, the things that we've learnt about. And I can give you a few examples of that. I won't go into huge detail about them, but we're keeping a listing of all of the things that we've learnt that are positives, and some of them not so positive, that we need to be aware of going forward. So an examples of that is that while we had our pandemic stock available, and we've kept that faithfully since the SARS scare back more than 10 years ago, we have realised that we have to be better at actually managing our total stock of pandemic supplies within our BA business as usual stock of those personal protective equipment items, so that we've got better track of turnover. So while we keep, I don't know how many thousand surgical masks, for instance, that we get better at actually rotating that through. And similarly with our N95 masks, having a cycling around that will be more difficult, given that we don't use N95 masks on a very much on a day-to-day basis. So it will be more difficult to be able to do that. I've talked about the virtual clinics and the benefits that we're seeing about that. We have particularly seen some really great advances in a way in which the team is working within mental health services, much more joined up between the various parts of that, including with the team at Hauora. And we can see some really obvious advantages around doing more of that going forward. We are aware that while we keep on training people in our coordinated incident system management, CIMS management system, we haven't trained enough people, and we need more people to be trained and able to take on those roles, particularly for a situation such as this. Most of our critical events are earthquakes or floods. They happen in a short space of time. There's a response in a short space of time, and then gradually things work back down again. With this event, it's been going on for weeks, and that has required us to keep up a high level of functioning in that incident management framework for over a period of time. And we need to make sure that we have enough people trained and knowledgeable around the SIMS structure, so that we can keep that running over longer periods of time, which will mean, like everybody else in the country, there'll be a real lot of people being trained up in SIMS as we come out of this. Having said that, what we've experienced in this is that a lot of people have really stepped up to join in that function. And I'm thinking that today, the team that is running our incident management team today is made up of a lot of people who've come along, observed, and are now taking on roles in there and doing that really well. So it is possible that people are able to step up for that. We're really pleased about how that has worked, but we do need more training in the future. The whole issue around the pandemic plan, we've had a pandemic plan since the time of SARS, and it's been refreshed on more than one occasion over that period of time, but it was very much focused in on a more flu-like event, that type of pandemic, than this virus, which of course is completely novel, and nobody was expecting that. I don't know how you can actually make a plan about something that you really don't know about yet, but you know, if you can do that, we need to have to do more of that going forward. We have found our clinical leadership to be really, really important through all of this, as per usual, and we've seen some really good instances around how that has worked, and we need to make sure that we carry that forward in our planning going forward. Our public health capacity has been great, and we've been able to redeploy other people working within other teams, usually people like health promotion teams who work closely with that team anyway, so that has worked well. But it's great to see the $55 million investment the government has made around public health that has, will make a big difference about what we're able to do with the capacity within that, and the resources that we will get here. We have learned a lot about how we manage our capacity as an organisation. We know a lot about that. We've got our care capacity demand management systems and our variance response management, all of those things that you've heard about. What we've seen over the last few weeks is very large positive variances within that system that are uncharacteristic, and we need to be able to manage that into the future about what we do around that. And I guess the last couple of things I'd say on that list of things there is the messaging around health services, that they're safe to use and don't hesitate to use them. the issue of residential care and the additional efforts that we put in, as was happening around the country, just to make sure that the systems and processes were in place. And Heather, I know you would want me to say that that your findings of this was that our teams here in residential care, not just Asian residential care, but in residential care in general, were well prepared, functioning well, had their PPE in place. There was difficulties in making sure they had all of what they needed right from the word go, but we quickly responded to that, and all credit to them for keeping the residents safe and having the systems available to do that. Our colleagues within primary care also, for reconfiguring the way in which they worked very, very quickly, that greater reliance on phone triage and people calling in and making sure that they came to the right place, and the setup of the community-based assessment centres, initially the specialist testing practices, and then later on the community-based assessment centre. We are very grateful to the team at Three Rivers Medical and other general practices within Tairāwhiti for the work that they did to set that up really very, very quickly, and the expertise that they've displayed in relationship to that. And if you haven't had a chance to see the video that the Gisborne Herald did on the CBAC in town, it's well worth a view. And similarly, the work done by Ngāti Pro Hauora with their equivalent testing service available at Tupuia, and the work that Tūranga Health did with the service out at Waikohu. I think a particular mention needs to be made of our GP liaison, Anna Muley, in relationship to that, because she has worked really, really hard to make sure that those systems and processes are in place, and the linkages between primary care and secondary care, to make sure that that works out very well. Psychosocial services. At present, we have seen a very great reduction in the numbers of people requiring those sorts of services within the community, but we are mindful of that previous experience around these sorts of events has meant that over time people do need those sorts of services, and so we're expecting that to increase. Personal protective equipment, I just noted there that there is the review that the Ministry of Health are doing around that. We'll be wanting to really join in with that, because we've got an interest about how that has worked out. I think Craig, I can see from here, he's got more grey hair as a result of this, as he has been, he and his team have been very much at the forefront of the issues around PPE. We're still not completely out of the woods in relationship to it. Things like hand gel are still an issue around the country, but I would have to say, Craig, you and your team have been literally tireless in making sure that where there was a need, then the equipment got out to them, and that includes our infection control nurse, Susan Egan, as well. Vaccination we've talked about. Just wanted to highlight also vaccination for influenza, that I haven't seen the latest figures, but I know that the rate of vaccination for influenza is startlingly high, both within our own staff and within the community. That's at the moment, of course, is for people, high priority, those people with long-term conditions, people over the age of 65 and pregnant women. So just an amazing effort put in by particularly our iwi providers to be out on the road most of the time during the lockdown, actually finding people and making sure that they have that protection. So just an amazingly strong effort there. CBACs we've talked about. Midland Clinical Platform, just to let you know that we put off implementing the Midland Clinical Platform next phase, which was supposed to be going live on the 27th of July this year, right very early on, because of the fact of us gearing up and not being able to attend to a discretionary task such as user acceptance testing and training to utilise the system. We're now going back into a decision-making process with our clinical teams around whether we are able to complete that upgrade of our systems before the end of this year. It would be before the end of November, so sometime between September the 28th, when Bay of Plenty goes live in the 30th of November, whether we can pick a date in that time frame that our clinical teams would support, because they're the ones that are going to be the ones that need to do the UAT and the training, and then be disrupted in that first week or two as we change over from one system to the other. Note, and I think it's mentioned in here, that there's a delay around annual planning. There's an expectation that next phase of annual plans won't be required until sometime in June. And Kim, you did mention before around building projects, so there's 3 or 4 that are particularly relevant for us at the moment. One is the demolition of the Morris Adair building, which we discussed with the contractors and agreed that we would not move on with that until alert level 2, because of the fact that that will require a group of people to come into our district from out of district, and at this point it is better that we wait and do that when we get to alert level 2, whenever that may be. But they're poised to be able to do that, and that will be good. Lift replacements, similarly, we are, and there's a paper on the agenda today around the tender for the completion of the 3rd lift, and again we would want to be able to proceed to have the approval to do that, but leave that until alert level 2. The rebuild of the mental health facility, we have proceeded all the way through this with regular stakeholder groups and discussions around preparing the business case that needs to go through the Ministry of Health and to Cabinet to get the final sign-off for the $20 million available for that project. And we expect that to be coming to the board next month, correct? Yes. And then that will then be, once we can get that phase completed, then we really get into the more detailed planning around the facility, and we are hoping to try and to be able to speed that up so that we could start building of that new facility next year. So bring that forward as much as we possible so we can contribute to the desire to keep the economy moving again. And another one that we have put off, but I just got confirmation today from the clinical teams that they are also keen to proceed, and that is the reconfiguration of our radiology department. That has been something that we've needed to do for some period of time to comply with licensing, with IAN's accreditation for the facility. And just got confirmation today from the clinical teams that they are very keen for us to get out to tender for that piece of work and have that ready to go when we move to alert level 2. So good news about that one as well. And then the last thing that I just wanted to say is two things. One is that just in general around the way in which Hauora Tairāwhiti staff have approached this whole situation, it's been scary for all of us going through this, because we haven't known with any great definition what would be happening. So we've made lots and lots of plans, and we've changed lots of things, and we've trained, and we've learned how to put on our PPE and take it off safely, all of those sorts of things. All of us have been exposed, like everybody else, to all of the stories from other parts of the world, the images of Italy and Spain and the United States and Great Britain with people in huge areas being coped with COVID-19. And so, it has been a very stressful period of time, but invariably we have seen Hauora Tairāwhiti staff and all of the other people involved in health services within Tairāwhiti really step up and across the way. And there's been some incredible amounts of commitment that people have put in, and everybody in every way has really responded to this. And right across the board, it's been a really amazing feature of what has happened. But of course, the converse of that is not converse, but the parallel with that, I should say, has been the response of people in Tairāwhiti and the whole country to abiding by lockdown and actually attending to the messages around that we can actually make a huge difference with that by actually making sure the virus is not transmitted, and remembering that we are the people that transmit the virus. And so while we within health, we're planning up for this disaster scenario, and let's be clear, we're not completely out of the woods yet in relationship to that, but while we were planning up for this disaster scenario, surely and responsibly and carefully, everybody in this community has done their bit by making sure that to date that disaster response has not been required and is becoming less and less likely to be required. And I think it's just really an amazing testament to what people can actually achieve when they get the message and they understand it, and they put aside whatever their thoughts may be about, you know, how this is going to affect me and my personal life and my business life and all those other factors, and realize I just have to do it because this is going to keep me and my family and everybody else in this community safe. So I'm really, you know, it's been great to witness that and to see the results of that, you know, as people have behaved so responsibly in relationship to that. We've had some really great support from our public health team, our public health physicians, and the rest of our public health team that have actually helped us to respond to the mechanics of this and to keep and to keep us safe. But it's really fundamentally the work that all of you on this Zoom call, all the people watching online, and everybody else within this community that have achieved, that have made the biggest and the greatest long-term difference around this. And of course, we're all having to keep on doing it. And the more we keep on doing it, the more the fear is gradually receding, and the more the chance of this turning into something more major is starting to recede. So it's a huge thank you, because we in the health system could never have done it without everybody else. So thank you very much.
Kia ora, Jim, and I absolutely want to echo your last sentiment. And you know, to be honest, the counterfactual, it would have been completely untenable if everyone hadn't done their part, and if the health system hadn't prepared for the worst case scenario and all things had come to pass, it would have been just awful. So thank you for your report. You've probably covered off another agenda item in your report, but that's great. So now I'll just turn to questions from the board. Tony, you have a question.
Thanks, Kim. Jim, I've been involved with my other job, preparing for level 3 and preparing our SOPs. What procedures have we got in place to ensure that our staff who are going out into the community have a readily traceable record of their movements? Just for example, in my own other job, staff are to travel directly from site to site. They're not to vary from the path. They are to keep accurate time records of where they go, who they interact with. There's a pathway to manage those records in the event of having to contract trace. Only one person per car. We have policies around vehicles, around cleaning vehicles, etc., etc. So have we got in place SOPs covering off those matters as we move into level 3, as we have moved into level 3, to ensure? I'm really concerned about particularly the traceability with staff. That's my question.
Yeah, so you'll be aware of the fact that we've actually been operating in this manner the whole period of time. So our staff have been out on the road, you know, all of those features around making sure that we're identifying who they're seeing, when they're seeing, where they went to next. We've got we GPS track our vehicles, so we know where people are. Yeah, so all of those things that you've just talked about are things that we've had in place right from day one, because that's what been our requirement. That's the nature of our business. So yeah, so while we've most of our mobile services will have been on the road over this period of time, but gradually that will expand. But that's the same principles involved for us, because we've been operating in that way as a business that's been in this all the way through.
I guess maybe my question should be more refined. So we've got the data, we've got the ability to see where people have been. Do we have in place a protocol to actually access and analyze that data urgently in the event of a serious issue arising? Because that's where the rubber hits the road, actually.
Contact tracing work. So whether it's a health worker out in a vehicle, a district nurse or anybody that's going out into or outreach immunisation service, whatever, or it's a person within the community, same principle applies in terms of identifying who that person's been in contact with. We've got we're a little bit of jump ahead of that, in that we've got that well documented around who people are visiting and when they were there, what time of the day, who else was in the house. Those sorts of things are there in place. So it's probably while we don't want to test it, it is probably easier for us than maybe other businesses.
Thank you, Tony. Heather, you have a question.
Unmute. Yeah, this is for Jim, and I acknowledge our IT progress has been changing directions lately. I'm just wondering if we're planning on e-prescribing in the near future.
Yes, we are, Heather. Just one of the topics that arose last week, and I don't know where we're at with actually investigating how we can speed that up, but definitely on the agenda.
Thank you.
Questions there too.
Nicola.
Just in response to Heather's question, Jim, due to COVID, our for the last couple of years, we've been working with our community to see if we could get support from general practice to pick up e-prescribing. As a result of this, we now have every practice on board with e-prescribing.
Are there any further questions of Jim from his very fulsome report, or areas that people would like to discuss?
Hickey's waving.
Oh, Hickey.
Thanks, Kim. My question relates to how do we continue to keep the community on board, knowing that the messages change. That's one of the things about this is every day there are changes. Every day, it's about making sure we're ahead of the game and that we keep our community informed. So now, and we saw that with the mobile testing up the coast where all roads led to Wharekahika, and interesting enough, other communities along the coast expected to get the same visit. However, there was a change in how we then did the testing, and now the main message is go to the CBACs if you have symptoms. And so my question therefore also involves, how do we continue to keep the community on board, because those messages are not actually getting out at the community level, the changes. And then the second thing is, will we therefore expect to see a drop in the numbers of people being tested? Do you think we've reached the peak of numbers being tested?
Yeah. So the community-based testing that we did we've been doing over the last couple of weeks was to do two things. One was for the health system, for ourselves, to be able to see whether we're going to whether we could identify whether there was any evidence of the virus hiding away in some of our communities. I know that there's been a degree of concern, not only from our public health physicians, but from other people within the community, that maybe that all of the people being tested were people maybe more in Gisborne, and certainly when the case definition originally was that you had to be overseas or had been in contact with a person with COVID-19, then that would certainly be more of the case. So we worked on it, and we built up this idea and a system for getting out to smaller communities, and also communities where there were greater numbers of people in bubbles, so larger bubble, people with larger sizes of bubbles, to see what it looked like. So that was one of the reasons that we had to do that. And we set that up, and then got a phone call from the Ministry of Health saying, could you do it? So that's was very fortuitous that the two things lined up. So that was one reason. And the other reason was really to respond and to those communities that were concerned that they were not getting the degree of testing, and concerned that maybe the virus was lurking within their communities as well. So we've been able to get out there, and we have provided that reassurance to people that, you know, of those, you know, with huge amounts of testing. I was just looking at the figures in the last 3 weeks. Last week we swabbed, did 918 swabs, and the week before that we did 425, and the week before that we did 199. So you can see that we had that massive increase in the numbers of people in the community who are being swabbed. And I'm confident in saying that a large proportion of those people were asymptomatic. But, you know, there is the view that sometimes people can be asymptomatic and still have the virus and pass it on. But we've been able to show actually in our community with large amounts of swabbing, we haven't been able to find the virus. So that's reassuring. But we can't keep on doing that. You know, now we have to actually be focused in on those people who are symptomatic, because that's what we should be looking for. Each of us as an individual, if you start to have any symptoms, you need to come out as family members and people in your bubble. As you start to hear of people, you know, with a sneeze or a cough or you know, that runny nose, what's that about? You need to be encouraging everybody to come out and get testing. And I think that I'm hoping that also what we've been able to achieve with this large rate of testing is to actually take the stigma out of it. Okay, you know, yep, I've got symptoms. I went along, I talked with my GP, I was recommended to get a test, I got a test, and, you know, we're hoping for 100 times out of 100 that test will come back as negative. But we'll all be reassured, and also if it does come back as positive, we'll be absolutely onto it to be able to trace how that could have come about and done that. So yes, the messages have changed, and we have to be effective now in actually telling people. The message now is we've completed that period of time of testing people more widely in our community and those focus areas, and now we're on to what we absolutely have to focus on now, which is part of our elimination strategy in the country, which is to find people as quickly as we possibly can who have the virus and contact trace and make sure it doesn't spread.
Thank you. Thank you, Hiki. And just before we go to you next, Meredith, I did just want the board to know that the community testing through the mobile clinics and the ability to test asymptomatic people is something that we've only had available to us because of Jim's representations to the ministry. So originally, the ministry chose some areas for community testing to look for community transmission, and we had no evidence of community transmission. So you'll recall they chose some areas in Queenstown and Auckland supermarket car parks, and Jim's particular representations about the nature of our geography and the vulnerability of some of our populations meant that we actually were able to conduct the community testing and give ourselves as a community a much greater level of assurance and comfort about what our COVID picture looks like. So I think it's important that we do just understand and acknowledge Jim's representations on our community's behalf on that. And Meredith, you have a question.
Kia ora. Listen, it's just an HR question. It's something I've been thinking about in respect to human beings following the rules. As Hiki has noted, changes constant in the space of what we can work with, our givens and the uncertain. Jim, do we have to, like what I was thinking about was, do we have to change any or updates practice-wise so that what do people do if they don't follow the rules? Like, will you know, in respect that we've had ministers not follow the rules, so to speak. So is there any concerns? You've kind of reinforced that everybody seems to be on board, but do we have to consider that what will happen if someone says, oh, actually, I'm not going to go drive straight there because I got a call that auntie needs this or whatever. I'm just thinking about that typical human nature to abide by rules where we get a lack. So is there a need to up in regards to HR in respect to not following the rules?
Yes, because we all need to be being constantly reminded about what the rules are and have those really clearly displayed for people and understood. But as you said, you summed it up really, I think, human nature. So we do know that there are going to be instances where people aren't going to be able to do that, attend to that. I think what we've seen in the community is that there's very few instances where people have deliberately not followed the rules. Most often it has been a lapse of judgment, even from the Ministry of Health.
Unless you're a
particular
surfer.
moment. Sorry?
Unless you're a surfer. There've been some issues.
Yes, but I think, that, people would have thoughts about, okay, I'm out there by myself, there's no risk to others, forgetting about the fact of, the whole point of that was people not undertaking activities that may be more risky, and then somebody else having to come out of their bubble to actually save them. So, I think as in any case, people's understanding can sometimes be different, and we just need to keep on re-explain to people. But and in many respects, these are habits of a lifetime that people have got, and you're not going to change habits of a lifetime within a short space of time. You can change a lot of it because people attend to something that's a threat to them personally and their families, and attend to that very strongly. I need to change this, otherwise, my members of my family may get this virus, and that may have dire consequences for them. And people, but as the fear of that recedes, then we will have to be more strong about those things, and about reminding them. And the thing that really concerns me a lot about this is that, from my own personal experience, I've reminded myself a lot about hand washing, about keeping my hands away from my face. But I just noticed already that I'm less inclined to do that. And my sneeze etiquette, I've been really good, I'm strong on that, but I have to be really careful about that. And I think we have to be very careful about reminding our family members and the other people that we meet. I know that I have had to remind people around this organisation at times around the distancing between themselves and making sure that they've got those distances going, and we'll just have to be very, very careful about that, and everybody needs to be part of that.
Cool.
Amy.
Can I just ask a question around any changes to the tangihanga process, and if now that we're in level 2, has the policy around deaths in the hospital changed, and that whānau and cultural aspects, and how that's been acknowledged?
Kim, do you want to talk about from a community perspective about that, or Josh? Because I don't think that things have actually changed from a community perspective. Certainly, we haven't changed at alert level 3 at this stage around that from a hospital perspective. But I do think that did change as time went on, and there is the ruling around people within a bubble being able to take part in burials, etc., over that period of time.
And can I just ask who wrote the policy around? Like, I know the government, put the restrictions around it, but did they also write the policy of how a death is treated at the moment?
So for tangi, now there is an ability to hold tangi with a maximum of 10 people attending, but with no kai, and no kind of wake or reception or anything afterwards. So it's possible now, but still very, very limited. In terms of processes for when there is a death at the hospital, Jim can speak to when someone is involved in end-of-life care, and what provision we make for visitation around that, and what occurs at end of life. You're on mute, Jim.
I've just turned off. So we followed on the national guidance around that in terms of having some discretion around people visiting people with end-of-life care, but restricting the numbers of people that can do that, and making sure that we have the details of who is that person that's providing that support of end-of-life care, so that we can contact trace if necessary as well. So we followed that. The Ministry of Health put out guidelines around that as well very early on, that they had consulted on with iwi leaders. So that's where the authorities come around those requirements.
I think that was my main question, was like how much cultural input was put in place when they made the tangihanga restrictions, and yeah, if there was much consultation with Māori around how that took place. But yeah,
Can I answer that question? As I understand it, the Ministry of Health put out guidelines through John Whanga's team, and those guidelines went through to all the iwi leaders. So within our organisation, Peter Brown, the Māori Health Manager, and the guy who's in charge of the emergency planning, Jim? Steve Hooper. So they put their, the organisation protocols based on what the government had put through. And then Peter was also in contact with David Parker from Evans. And so at that stage, there's always been that level of communication. And David Parker, through the Funeral Directors Association of New Zealand, their guidelines or their protocols are extremely strict. So what Peter and his team were trying to do was look at where was the opportunity for flexibility within Māori on the coast, and there really isn't a lot at all, except that at the passing of the person, whoever was involved in that person's bubble, at the discretion of the nurse manager, was able to be present. And from there, then down to the mortuary, then on to the funeral director. And that's where the level of flexibility could come in. At level 3, your bubble increases to 10. But as Kim was saying, no kai, no socialising, and that level goes through to the urupa.
Right. Oh, thanks for clarifying. I just wanted to, check if there was consultation happening at that level.
Absolutely, absolutely.
Thanks.
Are there any further questions of Jim? Rob?
Cool, Jim. I just put it in our chat. Can we get a report and have the presence of the Māori Health Director, Peter Brown, at our hui in the future to give us ongoing updates on Māori responsiveness?
Sure.
Kapai, anything further? If not, we will thank you very much, Jim. We will note your report and move on to the summary financial report. Craig, is there anything additional you want to add to the comments Jim's already made on the finances?
Probably just a couple of things, Kim. Just knowing that we're 191 adverse to budget for the month, the bulk of that's sort of taken up by the 150 non-specific accrual and 20k in additional PPE. So that's 108% over budget on PPE. Cash is holding up, as Jim mentioned, so 4.3 an overdraft. We'll see a nice correction in our balance sheet, both equity and current assets in next month's report. Capital expenditure with effectively 5 million favourable against budget in CapEx, just to the slowdown over the last 5-6 weeks, and it's probably going to go on for at least another couple. But we're sort of positioning ourselves to come out the other side of that and be able to ramp back into these capital projects. That's that all coming up.
Does anyone have any further questions on our finances for Craig? Rob?
Oh, Craig, I just wanted to check, and I was going to, I think I was going to raise it this afternoon, but just checking in with you in terms of whatever subsidies or government assistance we could access. What's the process for determining whether or not we were eligible and whether or not we are going to make those applications.
So is that relating to COVID-19, Rob?
Yeah, so that's the specific, so I think the specific query I had was those that were entitled to any particular subsidies, or, you know, depending on what type of work they were or weren't involved in. Yeah. Like whether they may have been required to stay at home. I'm not sure if it's relevant. If it's not relevant,
I think are you talking about like wage subsidies for people, that sort of thing?
Yes.
Yeah. So that doesn't, those wage subsidies, we're not eligible to apply for those wage subsidies, but yeah, because we're being funded, you know, to continue on the provision of our services. So we haven't had that same change in funding as other providers have had. So yeah, those wage subsidies don't apply to us.
I think with those, Rob, you have to demonstrate a loss of 30% of income to be eligible. Andy.
Yeah, just wondering if you give a bit more clarity around the non-specific expense accrual. It's gone up heaps, and I'm sure that's COVID related. So what can we expect with that figure going forward?
Yeah, thanks, Andy. Yeah, not related to COVID-19 at all. That's just generally sort of accounting for our year-end position, which has been some quite variation in previous years. So we have up the non-specific accrual, which typically was around 40,000 a month, up to 150 a month, just so we're flattening our expenditure across the year, not getting a nice big surprise come period 12 and period 13 adjustments.
I think for me, it's about understanding what the non-specific actually means.
A couple of things.
It's non-specific.
Yeah.
It's
so
basically just
so UN creditors and revaluations of leave liabilities. What else in there? Long service leave. So a lot of sort of provision revaluations specifically.
So in a nutshell, each year when we get to the end of the year, there are, as Craig's talked about, there's period 12 and period 13 adjustments in areas like you know, accruals that we may have in place for or provisions for leave entitlements, CME, those sorts of things, and other factors that get revalued at an end of year basis. And that invariably results in a change in the financial position of the DHB at the end of every year. So we have been in the habit of, probably for 15 years now, of putting in a non-specific accrual each month as the year goes by, so that we've actually provided for those. So by the time the end of the year comes, we've actually included that in what our financial position looks like. Usually around about $40,000 a month suffices, and in fact, actually, when you take all the unders and overs last year, $40,000 actually a month did it, which is about $500,000 at year end. But we did make a decision to up that this year to be even absolutely more certain. So we went from $40,000 a month to $150,000 a month. So at the moment, year to date, we've got nearly $1 million more of accrual sitting in there that may or may not be necessary. So we will see in a couple of months' time.
Yep.
Okay, if there's no further questions of Craig, well, thank you and note. Oh, sorry, Tony.
So just for clarification, we were tracking for a 14, so we asked for 12.4, we're tracking for 14. Are we still tracking for $14 million deficit?
We've got a budgeted deficit of 12. That current forecast that is in there is saying just over 14. So 40. That is, yeah, so that's where the current forecast is. But I'm not sure if you're referring to the equity injections or just the 14. No, okay, good. That's good. You've got it.
But then now we've got sort of more unknowns that are brought in, like you're talking about, like with electives or planned care, and so that just sort of provides more uncertainty about whether the result's going to finish.
It'd be good to get heads up if you're foreseeing an early blowout or bubble or something coming down the track. Heads up earlier than after the fact would be great. Thanks.
Yeah, sure. Yeah.
So we do get the forecast every month.
What Craig's referring to, though, is that the forecasts are more difficult at present because we don't know what the effect of COVID-19 will have. We definitely know there's more expenditure, but then we also know that there may be less expenditure in other areas, but then at the same time, we're not sure what might be happening around areas like planned care funding, whether that will continue as normal. At the moment, we are projecting that that will, but maybe that won't.
Yeah. Is there any wash up in PPE? We're not sure. A lot of the PPE that we've been handing out, so the likes of masks and gloves have been replenished from the National Centre, but the likes of gowns, aprons haven't. So we're not sure if that's going to be funded or the DHB's is going to wear that as part of their stock and their cost.
Okay, thank you very much, Craig. So we'll note the financial report. We have no subcommittee reports this month because last month we decided to shift all committee items directly to the board to keep our the burden on our staff at a minimum during this particular period. Item 7.1 is a COVID-19 verbal update, which, Jim, I think we've probably covered in your CE's report. So we'll just note that that item's been covered already. And then we move to our last item in the public session, which is the lift replacement proposal, item 8.1. So Jim and Craig, if you can take us through this. My understanding is we've done one, we've got one underway, and this is for the third one, and it'll take a bit of time to get there given that the lift has to get made and arrive.
Yeah, thanks, Kim. So this is, like I say, this is our third lift of 3 lifts. So this is lift number 2. And so this is decision paper for that. You're right, there's a 20-week lead time from if this gets approved to signing on the dotted line for the lift to be manufactured in China. All the Cornea plants are up and running and good to go. So that won't be a problem, but we've still got a 20-week lag time from getting that contract signed, the project commenced, and arriving here. So that we should hopefully after 20 weeks we should be well and truly into level 2 or into a better space by then. The tender price is 212,125. We've got an option of a 3-year maintenance program or a 5-year. 3 years being 6,195. The 5 years 5,950. So recommendation is the 5-year maintenance program. And cash flow, so 30% upfront, 60% on presentation of bill of lading, and 10% on commissioning of the lift.
Thank you, Craig. There were just 2 matters I just wanted you to give a quick, hopefully yes to. One is just confirming this process has been through GETS and met government procurement guidelines.
Yes.
Good.
Well, the initial program did go through for the first 2 lifts did go through GETS, and this is just like a follow on with the existing provider.
Yep. And the other question is that lift number 2 will be completed before lift number 3 gets taken out of commission.
That's right. Yes. I understand if lift number 3, the second installation is close to being completed. So once we get the gentleman back on site, to finish that off. It shouldn't be too far away.
Which is the bariatric lift.
It is the bariatric lift.
Sure.
Yeah.
So just to be clear that the second, unfortunately, the order that we've done them in is different than their numbering of the building. So it just makes it a little bit more complicated. But yeah, if we just say that we've done one, number two, the second one we've done is just about ready to be done. That is the lift, the bariatric lift. So the bigger size internally to cope with bigger beds and such like, and more equipment. And then the third one is the final one, which is the one that we're putting forward for approval today to complete the set of 3. And I guess the only other thing I just mentioned is that the capital for that is coming out of that. Isn't it not? We're using the balance of the $3 million, that we got for MAB, the demolition and planned preventative maintenance capex.
Okay. Now we've got Tony.
Andy was before me, Kim.
Oh, sorry, Andy.
That's all right, thanks. Yeah, the recommendation is whether we go for 3 years or 5 years with the maintenance program, and the recommendation is for 5 years, which is sensible. I just wanted some clarity around whether that maintenance program should actually start in the 21-22 year, because you wouldn't expect it to require too much maintenance in year 1 of a brand new lift.
Yeah, that's right, and I think that's in the proposal. The first year is included.
So happy with the 5 year myself. Yeah.
Great.
So, a similar question, but my question was that price for the 3 or 5, does that take into account the fact that we've got one other lift provided by this provider, and then we're going to have another lift provided by this provider, and therefore there should be some coordination around the maintenance programs, which would mean, I would imagine, one technician traveling to Gisborne as one occasion to service 3 lifts, as opposed to coming 3 different times. I just was making sure that that price reflected potential savings in coordinating the maintenance program. That was all.
Possibly. Yeah, I mean that's we've had quite a strong negotiation throughout all 3 of the lifts, and that's the maintenance per lift.
There's some factors that won't be able to be economised. I mean, certainly the visits, yes, that can be economised and will be. But some of the factors in terms of the actual maintenance, the equipment, and the actual maintenance items on the list that's included within the maintenance, each lift is separate from that respect. And it's 3 of them, so you know.
Yeah, so this one's a little bit more expensive, the maintenance on these ones, because of the components that are in it. So even though we've only got, we've got 3 floors, it's got a core functionality. Yeah, not sure if it adds any value to it, but the price differential was a little bit, but not significant. The benefits outweighed.
Mm-hmm.
Certainly read well as a product. I read the specs and the savings from its smart lighting systems, etc., etc. It's really great. So good. Which then made me think about, do we have a program, because I haven't seen anything enrolled to date around rationalization of lightings to make savings and LEDs throughout the hospital and that sort of stuff. But that's for another time, that conversation.
Sure. Yeah. And we did have some urgency around this. Did we include this in next year's capital round or the following? Yeah, we've got 2 new lifts, so we've got a good selection of parts. But then we've got also, there's going to be a big program up in Auckland. I think they're looking around 100 lifts across the Auckland campuses, hospitals up there to be sort of replaced. So we either get it now, or we could be on the, we're not going to see you for the next 5 years.
When might you get a confirmation on that?
That's why we're getting it now. That's why we bought the capital for this procurement for this lift installation.
Right.
So we've got a 20-week.
Oh, yeah, cool. Well, I like the 5-year maintenance program, and it looks like a good deal. So Yep, it's got my vote.
Are there any further comments on the capital proposal? In which case, do we have someone who will move the recommendations to approve this proposal and the 5-year maintenance program?
I'll move it.
Thank you, Tony. And a seconder? Rob, all those in favour, raise your hands. Thank you. And nobody against? And so that's passed. Thank you very much. So just before, this brings to an end our public session. So just before we move into the public excluded, for those members of the public and the media who are still with us, thank you very much for joining with us today. It's been a pleasure to have you. We're always very keen when members of the public participate in our processes and local democracy, so ka nui te mihi kia koutou. We now need to move the resolution to move into our public excluded session, where we will be considering the minutes of the previous in-committee meeting, relevant action items, correspondence from Audit New Zealand, and a financial update specific to COVID-19. And the details of the reasons for that are in the papers. So I will move that we move into public excluded. Do we have a seconder, please? Thank you, Josh. All those in favour? Ka pai, thank you very much. Thank you all for joining us. For the board, we're going to take a 10-minute comfort stop and reconvene at 11:15. Ka pai? Okay, see you soon. Thank you.
I'll leave the Zoom open.